Welcome back to session 3 of the PowerPoint. Today we're going to discuss oral diseases. So what's some terminology used to describe oral lesions? You're going to hear the dentist use different terminology. So let's talk first about the word lesion. Lesion is just a broad term for any abnormal tissue in the oral cavity. It could be a wound, it could be just a simple sore, and any other tissue damage caused by injury or disease. So you could have a lesion where maybe you had damaged the tissue with a potato chip. That's still a lesion, but it's an injury type thing. So just always remember lesion can mean a broad term. So how do they determine the type of lesion in a disease? That's one of the earliest steps in making a diagnosis. So let's look at the types of lesions of the oral mucosa as they are classified. They're either going to be extended below or above the surface. They are flat or even with the surface. And so maybe they may project up above the tissue, or maybe they're flat and go deep into the tissue. So those are two different ways that they will start classifying these lesions. So what's some historical information about lesions? Could be a family history. That's very important. So when the dentist sees any type of lesion in the mouth, it may lead them to talking to the patient about genetic disorders, such as dentiogenesis imperfecta. This may be passed from generation to generation, and I believe we talk about that later in the PowerPoint. Melanin pigmentation of the gingiva, which is common in dark-skinned individuals, and we've talked about that, I believe, in session 1. So, was it always there? That's a question the dentist will ask the patient. Has this area always been here? Sometimes the patients will say, oh yes, it's been there for many years. Or, when did you notice it? And then some patients will say, well, I noticed it 2 years ago, or, I just noticed it this week when I was brushing my teeth. So you have to get a little history on these lesions to kind of put the puzzle together. So as the dentist looks at these lesions and decides how to diagnose it, so what kind of information they need, they may ask for this historical information, which is what we just talked about. How long has it been there? When did you first notice it? That type thing. Then they'll look at the clinical appearance of it. If it's something that they think would show up in a radiograph, they may have you take an x-ray of it. Laboratory findings through a biopsy. So microscopic, which is again through the biopsy. Surgical would be to remove it and then have it biopsied. Therapeutic, and we'll talk about that in a few minutes. And then the differential findings of a lesion. So the dentist thinks about a lot of different things and tries to put the puzzle together with the pieces to decide, exactly what all do they need in order to make this diagnosis of a lesion. So let's think of examples of conditions that are diagnosed on the basis of clinical appearance. These are things that can be diagnosed and they're normal, okay? One that we have listed is a fissured tongue. The other is a maxillary and mandibular tori. And we talked extensively about that in session 2. And again, those are normal, so the dentist can simply look at those and say, oh yeah, that's a normal, probably been there for a long time, maybe the patient hasn't even noticed it. Then you have the median rhomboid glossitis, which again, with the glossitis is referring to the tongue, and we'll talk about that in a few minutes. So looking at radiographs, does the dentist need a radiograph to make a diagnosis? Maybe, and then sometimes they do not, but they are excellent in providing information about periapical pathology. Remember, the dentist cannot see what's at the apex. Internal resorption, we've talked about internal and external resorption. So the internal resorption, the dentist cannot see, they cannot feel with an explorer. Impacted teeth. Obviously, the dentist is going to need a radiograph to see any impacted teeth. We always think about third molars, but sometimes the maxillary canines can be impacted. So it's not always the third molars that we think about with impacted teeth. So there we could do a panorex, and you've been doing your reading about the extraoral radiographs. Pathology that's hidden in the mandible or the maxilla, so maybe in the bone, and we're going to talk about those probably next session. So the pathology sometimes requires a radiograph. Okay, so periapical pathology. So if we look at this, we can see this area here looks very different. Something's going on here. We have a radiolucency. So here we have a periapical radiolucency, or some dentists refer to it as a PAR. So that can be an area that they're seeing here at the PDL, and some difference between the discoloration, the radiopaque, and the radiolucency. So here, notice this real dark, I'm sorry, not dark, but deep restoration here. So it's getting pretty close to a pulp horn in this area. So, you know, that could be causing this tooth maybe to be dying. So we don't know, but that's periapical, and obviously a dentist could not see that without a radiograph. Okay, here you have, some people call it a parulus. Some people call it a fissure. It's an abscess. So basically this first molar here has an abscess on it, and this little parulus or fistula, whatever the dentist wants to refer to it as, is really where the infection is trying to come out and release to get a way to drain. So typically a patient will say, I've got a little bump here on the side of my gum below this tooth, and typically when they say that, most of the time it will be the tooth has abscessed, but this is where it's wanting to drain from the roots. So you could call it a fissure, you could call it a parulus, or you could simply call it an abscess. Okay, so looking at internal resorption, this again is something the dentist could not see without the radiograph. So if you look at the area where the arrow is pointing to, you notice this tooth area right through here is starting to dissolve. Now, just to look at these radiographs, you may think, well, I don't think that's all that noticeable. But believe me, to a dentist eye, they're going to pick up on that very, very quickly. Okay, here is a horizontal impacted third molar. So if you look at this, you will notice the third molar sitting here, it is horizontal. The way this tooth is impacted and up against this second molar, you have two problems. This impaction will never erupt into the mouth. So in other words, it cannot turn and get up and come straight up into the mouth. It cannot erupt. It is impacted in bone and it will not move. The second problem you have is the longer it sits here, the more it is destroying this distal root of this second molar. So really this tooth should have been out much sooner than it is. Shouldn't still be there. But those are the problems that these horizontal impactions can cause. And again, if you don't have radiographs or a panorex, the dentist cannot see this. Okay. So what about microscopic diagnosis? So when a suspicious lesion is present in the mouth, or the tissue is removed and sent to a pathology laboratory where it's evaluated, and we just simply call it a biopsy. There's a couple different types of biopsies that dentists can do, but the procedures often used to make a final diagnosis. The dentists typically do not know what things are unless they do a biopsy. Now, they may have a name for it, but they may not know whether or not it's a benign or a malignancy. So they typically will do some type of biopsy on it. Okay, this way that helps them to know for sure exactly what it is when the pathologist looks at it under a microscope. Okay, so a white lesion cannot be diagnosed on the basis of a clinical appearance alone. Red lesions, a little more definite diagnosis with those, but when you get into the white lesions, a lot of times they can't make that diagnosis without some type of biopsy on it. They need to know what the cell structures and the tissue organizations are when they diagnose it and determine that. So here's an example of a white lesion. It's seen on the anterior floor and the ventral surface of the tongue. Now let me show you. You may say, well, I don't really see anything all that suspicious, but for a dentist looking at the tissue, this is very suspicious. So if you'll look at this area in here, and with the tissue colors being red and pink and blues and whites, sometimes it's hard to diagnose, sometimes it's hard to even notice, but this area in here would become very suspicious to a dentist if they saw this under the tongue. This is one reason it's very, very important that people have an oral cancer screening. We've talked about the soft tissue screening in lab when you handed the 2x2 to Ms. Thompson or myself, and we pulled the tongue out and looked at it. So that soft tissue exam is very important because typically you're not going to see under the tongue like that. So the dentist or the hygienist or both will do an oral cancer screening. Okay, let's talk about therapeutic diagnosis. The therapeutic diagnosis is made by providing a treatment therapy, then seeing how the condition responds. So for example, what type of condition would the dentist maybe use therapeutic diagnosis for? Well, here's one. It's called angular cheilitis. Some people pronounce it cheilitis. But either way you want to pronounce it, I think would be acceptable, but I'm going to use cheilitis since I believe that's the way it's used in your book. So angular cheilitis, a vitamin B complex deficiency. So this could be someone that is suffering from a deficiency in vitamin B. The lesions found in the corner of the mouth involving both the mucosa membrane and the skin. It can have an overgrowth of Candida albicans, and that is a yeast infection. So what's the treatment? Antifungal agents, have a vitamin B supplement. A lot of people that wear dentures will suffer from this because the mouth is overclosed. They don't have enough what we call vertical dimension. So might need to remake their dentures or their crowns to increase that vertical dimension. So looking at the picture here, I bet you've seen this before, angular cheilitis. You notice it is involving the lip, and it extends to the tissue, and it really is this whole area here. It goes up and comes back down into here. So this can be very sore. So think about if a person has a vitamin B deficiency. Now, if you're wearing dentures, and a lot of people take the dentures out of a night, you're going to have saliva pooling in this area, and that keeps it moist. And so a lot of times in elderly people, you will see this. So they can do this with a therapeutic diagnosis simply by prescribing the antifungal, getting on some vitamin B, and then see if it clears up and see if they can figure it out by doing it therapeutically. Okay, and then we come to our surgical diagnosis. It's made on the basis of what's found in the surgical procedure. Cyst, traumatic bone cyst, static bone cyst. However, one condition will require treatment and one would not. So they have to know what they're dealing with surgically. Sometimes it's just something that can be left alone. Other times needs to be removed. So here's an example of a traumatic bone cyst, this radiolucent area in here. And again, you'd have to have an x-ray to see this. So this is what shows up on panorexes and things like that, that the patient may have like every 5 years. Okay, this one is a static bone cyst. Okay, so there's a difference between the two, and the dentist would decide, okay, oh, this is something that is okay, that we know it's there, but it's not going to cause a malignancy or damage anything, and this one would be something that they would have to remove and check pathology. Okay, differential diagnoses. So different ways they can diagnose on symptoms, appearance, or characteristics. You know, questions, the onset, the appearance. What symptoms does the patient have? Any symptoms with it? Biopsy, radiographs, and surgery. Okay, we're going to stop there for this session, and the next session we will pick up. We will talk about inflammation and probably try to move on with this pretty quickly.